Marcia Mangiza. I am a neonatologist from Zimbabwe. I work both in private and in public. And today I'll be presenting to you just a very short presentation on approach to respiratory failure in neonates. I'm hoping that we all watch the videos of the third module on respiratory failure. So I just want to give a brief overview on how to approach a baby who's got respiratory failure. So as a definition, respiratory failure is when you have an inability to maintain either the normal delivery of oxygen to the tissues or normal removal of carbon dioxide from the tissues. And you can remember that for medical school, it is divided into type 1 and type 2. So type 1 is hypoxemic respiratory failure, where the baby is failing to oxygenate and the baby is hypoxic with SATs that are below 90%. And then type 2 is ventilation or carbon dioxide removal, where the baby has difficulty in removing carbon dioxide and you have a high PCO2, or maybe because the baby is apneic. Most babies will suffer from type 1, which is the hypoxemic respiratory failure, but sometimes one type can also lead to the other type and it becomes a mixed picture. Okay, so just from the definition, it SATs less than 90% and a pressure for oxygen less than 50 millimeters of mercury. And then whenever you've got a baby who's got respiratory failure, who's got SATs less than 90 or a PaO2 less than 50, you must consider using an objective scoring system to guide the team. So I think we learned earlier on about the Downey score for respiratory failure, and there's also the Silverman-Anderson score for respiratory failure. And then you need to decide on what sort of support the baby needs. Does the baby need oxygen only, or does the baby need oxygen and pressure? Some references will say for babies less than 32 weeks or less than 1,500 grams, you need to try CPAP, which means you need to try oxygen with a bit of pressure. So I'm going to talk about the different methods of respiratory support and how you sort of decide on which method of respiratory support to use. So we all know what CPAP is, which is continuous positive airway pressure. It's a modality which was discovered more than 70, 80 years ago, but in the last 2 decades, it's become one of the primary methods of support that we use in neonatology. And what does CPAP do? CPAP provides a continuous positive airway pressure, and it provides one pressure. It provides a peak and expiratory pressure. And what that pressure does is it improves the lung volume, especially the functional residual capacity. We know that our babies, especially our preterm babies, when they've got a deficiency of surfactant, the alveoli collapse. So when you give them the PEEP and expiratory pressure, you improve the functional residual capacity and you improve the outcome of these babies. So CPAP should be started right from birth, according to the European Consensus Guidelines for 2022, I think. CPAP should be started right from birth in all babies who are less than 30 weeks. So we should be starting CPAP in the delivery room. It's been shown to have benefits. So the benefits of early CPAP include a decrease in invasive ventilation, a decrease in use of surfactant, and a decrease in bronchopulmonary dysplasia. Like I mentioned before, the PEEP prevents alveolar collapse. So there are many devices or systems which are used to deliver CPAP. So there haven't been any studies which have shown one device to be better than the other, whether you're using a bubble CPAP machine or you're using CPAP from a ventilator or flow-driven CPAP. But usually they advise that you must use short binasal prongs or a mask, and the starting pressure should be about 6 to 8 centimeters of water. And then CPAP can also, another indication for CPAP is it can be used when you're weaning from invasive ventilation. So let's say your baby has been intubated and you want to extubate your baby. Extubating the baby to CPAP has been shown to have a lower failure rate. That is lower need to re-intubate the baby, lower extubation failure rate. Okay, so I've just got a diagram here. You can see the first one is showing a T-piece resuscitator, which can be used in the delivery room, so that you start CPAP right from the delivery room. What it does is it provides PEEP, and it requires a gas source. So you need to have oxygen, and you can have a blender as well, together with the T-piece resuscitator, and you can titrate your FiO2 if you've got a blender up to 100%. It will and it can also be used to provide ventilation. So you can actually use it to provide a ventilation with a face mask, like you're bagging the baby. You can give PIP and PEEP. And then there's also this flow, the next bag mask for bag mask ventilation. So there are two devices. There's the one which is flow driven, and the other one which is not flow driven. So this one, the second one, it provides CPAP, and it requires a gas source as well, and you can use it an FiO2 up to 100%. And then the next one, which is our bag valve mask ventilation, which we normally use, which most people in low resource settings use. You can use it, but remember that when you're finished giving a positive pressure ventilation to your baby, it's not going to be able to give PEEP. So if you need to give CPAP in the delivery room, the one that is recommended is the T-piece resuscitator, which is your first device. Okay, and then there's something called Nasal IPPV, which is nasal intermittent positive pressure ventilation. So what it is you're actually delivering pressure at two levels. You're delivering positive inspiratory pressure and a peak end expiratory pressure. It improves respiratory drive, especially for babies who are apneic. So if you've got a baby who's got recurrent apneas, you can actually put them on nasal IPPV. It's been shown to have that you get improved outcomes. And you can also, there are also some ventilators which you can actually synchronize the nasal IPPV with the baby's respiratory effort. So there's devices that you can put on the abdomen to actually synchronize the IPPV with the baby's respiratory effort. And the settings mimic the same settings as you use in invasive ventilation. Okay, and then there's also high flow nasal cannula. So high flow nasal cannula, this is giving flow. It's providing inhaled gases at flows that are higher than the inspiratory demand flow. So usually for low flow, you use flows below 2, but with high flow nasal, 2 liters per minute. With high flow nasal cannula, you are using flows that are high, maybe at about 3 to even about 7 or 8 liters per minute. So what it does is that you wash out, there's a washout of the upper airways because of the gases, and you reduce physiological dead space. And there's also decreased nasopharyngeal resistance. So high flow nasal cannula have become quite popular in some areas because they cause less trauma to the nose. But as a primary mode of respiratory support, like in severely preterm babies just at 28 weeks, it's been shown that they've got a higher failure rate than CPAP. So CPAP is the recommended primary mode of respiratory support. And then they can also be used, high flow nasal cannula can be used post-extubation in the bigger babies. Those who are greater than 28 weeks, you can use high flow nasal cannula. So basically the devices that give high flow nasal cannula, usually you'll have a humidifier, and then you'll have maybe the machine itself, maybe like a vapotherm, and then you use the nasal prongs to deliver the high flow. And then low flow oxygen is what is used in most commonly low resource settings. So you'll be using flows which are 2 liters per minute and below. The gas is humidified, but it's non-heated. It's low cost. You can use the low flow oxygen where a baby is not very sick and you've got non-progressive disease, such as transient tachypnea of the newborn. Such as transient tachypnea of the newborn, and it can also be used as a method when you're weaning your baby from CPAP. As well, high flow nasal cannula can also be used when you're weaning your baby from CPAP. And then invasive mechanical ventilation. This is when you actually intubate the baby and you ventilate. So this one is, you then use this method of respiratory support if you've got persistent respiratory acidosis, for example, a pH less than 7.2, and a PCO2, which is quite high, greater than 60 millimeters of mercury, or you've got a high FiO2 requirement, greater than 60%, and it's rising, or you've got recurrent significant apnea, a baby who remains apneic and is recurrently having apneas, that baby needs to be ventilated. Or if you've got a baby who's got severely increased work of breathing, and you can tell that this baby is going to tire in the next few hours. Or if you've got congenital lung abnormalities that maybe are diagnosed either antenatally or postnatally, for example, congenital diaphragmatic hernia, you need to invasively ventilate these babies. I think we'll talk more about ventilation in the courses to come. Thank you.
Thank you so much. Your camera is off. I can stop sharing the screen.
Okay, stop share. Okay. All right.
Yeah, and keep your camera on. And I request the colleagues to keep their camera on during the interactive discussion stage. During the presentation, you can keep. So welcome everyone again. I think some of you joined later, but just to give you an overview of what Dr. Mangiza presented, she just gave us a gist of what options we have to manage respiratory failure. And of course, the key decision is to decide what you want to use when. So I think we can open to questions. Very nice presentation, and this is despite you're having a very busy attending week. I think you just prepared today, right? So well done, and it was very nice. You spoke very well as well. I'm sure the colleagues agree with that. I see some comments appreciating your presentation. So who wants to start the question? I mean, if you want to just unmute and speak.
Sir, I had one question. I'm Dr. Samarth.
Yes, Dr. Samarth, please go ahead.
Sir, I had one question regarding the post-extubation process. I had attended a conference before, and there it was told that post-extubation after an invasive ventilation, instead of bubble CPAP, HFNC is a better choice.
Yeah, I mean, a lot of colleagues believe different things. And obviously, the evidence base for high flow nasal cannula in a rapidly changing situation. I mean, you could consider it if you put it in sequence. Dr. Mangiza, do you want to answer that first? Sorry.
All right. Thank you so much. I think post-extubation, high flow. So I think with high flow nasal cannula, it will depend with the center. So there are some centers which have become very, very good at using the high flow nasal cannula, and they do well with it. But generally, the recommendation is that for babies who are less than 28 weeks, it might be better to extubate them to nasal CPAP and then use high flow nasal cannula as a downgrading from a nasal CPAP, just in order to reduce the number of extubation failure rates.
I agree. I mean,
because remember, it doesn't.
Yeah.
It doesn't give a consistent peak and expiratory pressure. The PEEP is quite inconsistent with high flow as opposed to with CPAP.
So we have a group of babies. Yeah, I'll just add. I mean, we have a group of babies who will do well with high flow at extubation as well, especially the babies 28 weeks and above who are relatively stable when you extubate. But the very tiny babies, there are studies which have shown that high flow is not the best mode. And if you look at Callum Roberts' study before on high flow, I mean, they had a higher failure rate, and the same that was in primary use as well as at extubation in the present 28 weeks. So you can use CPAP or high flow in the bigger babies, but in the smaller babies, especially those below 28, you have the option for NIPPV, use that as an extubation modality of choice, because the current evidence as well as the Cochrane review supports that. But it depends on what you have in your unit. NIPPV and interfaces like RAM cannula, which helps you to do NIPPV with a regular ventilator, may not be available with all. But if you have that, you can use. Does that answer your question, Dr. Samarth?
Yes, sir. Yes, sir. I got it. Thank you, sir.
Dr. Rajeshwar, do you have any comments?
Good evening, sir.
Hello, thank you. Oh, sorry, you can go ahead. I'll come up to you.
Very nice presentation by ma'am. And yeah, as sir told that there is different modes of weaning and deciding about which mode post extubation you tried for proper oxygenation. Still, I have personally my more experience with the extubation to CPAP mode rather than HFNC. Personally, I haven't tried HFNC that much as we have tried CPAP. So in the future, I would like to try more of an HFNC because it is very staff friendly and parent friendly mode.
One comment I would make here is that if you're using the RAM cannula, for example, even the NIPPV is delivered almost similar to high flow, the interface wise. But
Right.
only thing we have to remember if you're using the RAM cannula is that the circuit has resistance. So the settings you keep will be about 30% more than what you normally keep for. Suppose you are using NIPPV of 22/4 or 22/5, you will use 26 to 27 over 6 or 7. So what you read on the machine is not exactly what you get in the baby. You have to titrate it according to the baby's levels. But even when you increase the support, you don't see side effects. And that's what Dr. Ramanathan says as well.
Yes.
Dr. Lethil, you can carry on, please, with your comment.
Okay, thank you, Prof. Thank you, Marcia, for the presentation. Mine is not really a question, but maybe if you could just share your thoughts on this. From my experience, I work in the same unit as I work with Dr. Mangiza. We've noticed that for the very small babies, post-extubation, they tend to do better if we put them on NIPPV, and then we gradually wean to nasal CPAP, then eventually nasal prongs. So I don't know what your experience is. Do you have your NIPPV extubation, post-extubation NIPPV versus high flow nasal cannula or nasal CPAP? What is your experience?
Yeah, agree with you. I mean, most situations this would be the right approach, but you have to balance it on your equipment availability. Because NIPPV needs a ventilator to deliver it. So if you have a few ventilators in the unit, you need to prioritize. For example, you need to keep one ventilator for a new admission, which you can't predict. And if one or two small babies are there, you have to prioritize the NIPPV to them. And the bigger babies, you can extubate to bubble CPAP or high flow, which are less resource consuming. So if you have many ventilators, you can definitely extubate more babies to NIPPV. I mean, it depends on your unit size and what equipment you have. We have a full module, chapter in the module on extubation now, where I'll be discussing this in great detail. But in terms of respiratory failure, I mean, in what Dr. Marcia covered, do you have any questions?
No questions. Thank you for the presentation.
Dr. Maher, nice to see you here. I think you were going through an initial very busy phase, isn't it? Do you want to say anything about, are you able to catch up so far? Dr. Maher Akhtar, you can hear.
Dr. Sridhar, can I make a comment?
Yes, please.
So this is just to re-emphasize what you said and what the other colleagues have been talking. Gestations less than 28 weeks, evidence-based modalities of even systematic reviews have suggested that CPAP is much more superior to high flow nasal cannula in extubation. So I think the cutoff should be 28 to 30 weeks. Below that, you should probably plan to electively extubate to CPAP rather than high flow cannula. I hope, of course, NIPPV in case the respiratory efforts are not good, but I think CPAP is probably much better than HFNC in very small babies.
Yes, thank you for your valuable comment and thank you for joining us as well, despite your busy schedule.
No, thank you so much.
I see Dr. Priyadarshini, you had a very nice presentation last week, Dr. Priya. Well done. And is Dr. Prateen there?
Yes, sir.
Hi, you also did very well. Very interesting case. And what's most appreciable, as Dr. Karthik said, is that you were so honest with the way you projected things. I mean, you can easily make up things for the presentation to make it look nice, but you projected exactly what you did, and that's what we should do. I mean, you learn by expressing what you did, and I really appreciate that. Thank you.
Sir, I have two questions for this.
Yeah, carry on.
Sir, first is like in pediatric practice, we set a dose of 2 or 3 liters per minute for high flow nasal cannula. So for neonates, is it the same dose or should be less than 2 liters per minute?
Yeah, I mean, we have a concept about low flow. Low flow should ideally be avoided in neonates for 2 reasons. One, at this flow of below 2 liters, you don't get any pressure. And as Dr. Marcia mentioned in the beginning, most of the small babies need pressure as well as oxygen, or maybe they just need pressure because of the low compliant state of the lung in most of the disease states. So low flow can be used in BPD patients who are weaning off oxygen. Apart from that, I don't see much of a role. Plus, remember that in the small babies, even the small quantity of gas flow that comes with low flow can make the temperature unstable because you're not heating or humidifying the gas. So even if you are using a flow of 2 to 3 liters while you're weaning the high flow off, prefer to give the high flow nasal cannula because you need a blender anyway, and you need the humidified gas to keep the baby comfortable. So stick to high flow whenever you need some flow support in babies. And the range is, starting from 6 liters. In the bigger babies, you can go up to 8 liters fairly safely. In the pediatric age group, when you manage RSV, of course, you can go to 14 to 16 liters. So in the newborn age group, it's 6 to 8 liters maximum. The small babies less than 30 weeks, stick to 6 liters as far as possible and wean gradually. If the baby is tolerating, you can reduce 0.5 to 1 liter every 6 to 12 hours. If the baby is not tolerating, it's okay to keep them. And as I mentioned before, the tiniest babies, we keep them on the high flow till they are about 1.5 kilos or so when they're ready to suck their feeds. I know practice is slightly different in India. You tend to discharge sooner, but here we tend to keep them till 1.8 kilos. So we wean off the high flow when they reach 1.5, 1.4, 1.5 kilos when they are around 32 weeks. And that helps to maintain their FRC. We discussed during the FRC presentation as well. So this helps to maintain their FRC and the frequent intermittent hypoxemic spells are reduced. If the baby doesn't tolerate 3 liters, you can increase it, but don't go below 3 liters because you don't get any pressure below 3. People do wean to 2 or 1 at stopping. Babies do get used to high flow. And initially when we introduced high flow, there were some reports that babies needed the support for a longer time when they're on high flow. But when we use it and we know that you don't really need to wean off, once you reach 2 liters, you just stop it. That should work fine. And the first 12 to 24 hours after you stop high flow or CPAP, keep them prone mainly. This helps them to adapt better when you stop the support. What was your